Bismillah ar-Rahman ar-Rahim. Our topics today about gestational trophoblastic disease. Gestational trophoblastic disease is a diverse group of diseases with abnormal proliferative trophoblastic production, exaggerated trophoblastic production by trophoblastic epithelium. هذه تشوفوها grape like تكون شكلها. الtypes of gestational trophoblastic disease: histological أو histopathological classification. عندنا benign و malignant. البناين هي 80% والmalignant 20%. البناين اللي هي تشمل لنا هادات formal molar pregnancy either complete or incomplete. المalignant تشمل لنا invasive mole, Cordial Carcinoma, chorioepithelioma, placental site trophoblastic tumor. The term gestational trophoblastic tumors has been applied to the latter three conditions, يعني invasive والchoreo والplacental site. Retain the invasive tendencies of the normal placenta or metastasis. Each one trophoblast equal to 1 beta HCG unit, which is very specific tumor marker. Pathological and clinical classifications for gestational trophoblastic disease. عندنا الباثولوجيكال قلنا الهادات formal اللي هي either complete or incomplete، والinvasive mole والplacental site trophoblastic tumor والchoriocarcinoma. الكلينيكال classification الهادات formal complete والincomplete ممكن تكون benign trophoblastic gestational trophoblastic disease وممكن تتحول إلى malignant. While invasive mole always malignant, placental site tumor malignant, choriocarcinoma malignant. المalignant trophoblastic tumors احنا نسميها ميتس أو non ميتس، يعني اكو عندها ميتاستاسيس واكو قسم ما عندها ميتاستاسيس. non metastatic ممكن تكون ميتاستاتيك. ميتاستاسيس عندنا هاي ريسك وعندنا لو ريسك. الهادات formal اللي هي molar pregnancy is a pregnancy characterized by vesicular swelling of placental villi and usually the absence of an intact fetus. The etiology of haadat formal remains unclear, but it appears to be due to abnormal gametogenesis and fertilization. Incidence 1 out of 500 to 600, another report 1%. Pregnancies in some Asian countries, 1 out of 1,500 to 2,000 pregnancies in the US and Europe. Complete more than incomplete, approximately 10 to 70% of haadat formal will result in invasive mole. Approximately 2 to 3% of haadat formals progress to choriocarcinoma. Most of them are curable. طبعا most curable disease عند الفيميل هو الchoriocarcinoma. الcytogenetics منين تجينا origin of complete and partial mole. Either empty ovum fertilized by 23X chromosome sperm عفوا، راح يصير عندنا chromosome duplication، راح تكون 46XX homozygous complete mole. أو عندنا empty ovum fertilized by 2 sperm، راح يصير عندنا 46XX أو 46XY اللي هي يسميها heterozygous complete mole. البارشيال مول راح تكون عندنا ovum normal اللي هي 23X fertilized by 2 sperm either 23X or Y dispermy. شو راح تنطينا؟ راح تعطينا triploid partial mole اللي هي 69XXX 69XXY أو 69YY. Clinical risk factors for molar pregnancy age extremes of reproductive years اللي هي either less than 20 or more than 35 years old. طبعا الريسك فاكتور مهمة جدا بالهدف فور مول. reproductive history higher hazard hormone 0.5 to 2% prior spontaneous abortion, diet, low levels of carotene, vitamin A, folic acid, the blood group, maternal blood group A and AB, ethnical and geographical, Asian women more than Western, infertility, nulliparity, oral contraceptive pills and smoking. كل هاي risk factors. Benign gestational trophoblastic disease, 80% uncontrolled non-invasive growth of trophoblast, complete mole 90%, very high beta-HCG level, maybe more than 100,000, high transformation rate to malignancy 5 to 20%. On ultrasound no fetus. هاي مهمة. شلون راح نعرف إنه هذه complete mole؟ راح نشوف no fetus, no amniotic sac, no amniotic fluid and large placenta because of trophoblastic overproduction. راح نشوف thecal uterine cyst, large uterus with snowstorm appearance يعني عاصفة ثلجية due to diffuse swelling of chorionic villi. هذني features مهمة. الsigns and symptoms of complete hazard hormone راح يصير عندنا exaggerated symptoms of hyperemesis gravidarum due to high beta HCG, vaginal bleeding most common حيؤدينا إلى anemia, passage of molar vesicles from the vagina, early preeclampsia before 20 weeks. طبعا هذه pathognomonic للهازارد hormone. إنه إحنا البريكلامسيا عادة نشوفها after 20 weeks. هنا لا نشوفها before 20 weeks. Photophobia, clinical hyperthyroidism هذه مهمة لكن ترمر because of alpha subunit of HCG stimulate the action of TSH. لهذا يصير عندنا clinical hyperthyroidism. Also alpha subunit of HCG stimulate the action of LH FSH and cause large thecal uterine ovarian cyst about 6 cm. هذه هم مهمة. ليش بيصير عندنا ovarian cyst due to alpha subunit of beta HCG which stimulate LH and FSH. Embolization, trophoblastic tissues may escape uterus through venous outflow. The emboli may lead to fatal pulmonary embolus, DIC, which is the result of the release of tissue thromboplastin into the circulation. Physical examination, vital signs, blood pressure, early PET, pulse rate, respiratory rate, tachycardia and tachypnea, and hyperthyroidism. Abdominal examinations, size inconsistent with gestational age, large uterus and abdomen with no fetal heart beating and fetal movement. Fecal uterine cyst, pelvic examination, bleeding on the genitalia, may see the vesicles, signs and symptoms of partial hazard hormone, vaginal bleeding, absence of fetal heart tones, uterine enlargement and preeclampsia is reported in only 3% of patients. Fecal uterine cyst, hyperemesis rare, low beta HCG. لهذا تكون عندنا sign symptoms قليلة. In partial mole, the mass may contain both these abnormal cells and often a fetus that has severe defects. In this case, the fetus will be consumed, destroyed by the growing abnormal mass, very quickly shrink. Comparative pathological features of complete and partial hazard hormone. The features عندنا karyotype, complete mole, usually diploid 46XX paternal, partial mole, usually triploidy 69XXX most common, paternal and maternal. Villi, all villi hydropene, no normal adjacent villi. Normal adjacent villi may be present. The vessels present, they contain no fetal blood cells. الفيتال تيشو راح نشوف هنا بالكومبليت نشوف non present, هناك usually present. التوفوبلاست هنا hyperplasia usually present to variable degree, هناك hyperplasia mild and focal. والبيتا HCG هنا نشوفه very high, هناك نشوفه less. Diagnosis, clinical manifestations, quantitative beta HCG very high in complete while less increased in partial. The ultrasound is diagnostic in complete مثل ما قلنا no fetus, راح نشوف snowstorm appearance, no amnion, no chorion, no amnion. الثيكال uterine cyst راح نشوف بالcomplete snowstorm appearance incomplete, no fetal heart sound, large placenta and large uterus, absence of fetus, incomplete mole. Histopathology is diagnostic and important in partial mole, not the ultrasound. لأن احنا راح نشوف اكو موجود بالبارشال مول، راح نشوف اكو بيبي موجود وموجود امنيوتيك ساك موجود، لكن شلون راح نعرفه بالهيستوباثولوجي لأنه لا اكو سنوستورم ولا اكو فيكال يوتين سيست. This is the picture of complete hydatform mole demonstrating a large villi of various size. هنا نشوف large amount of villi in the uterus. هذه شوفوا molar vesicles، هذين البيض اللي تشوفوهم. The microscopic appearance of the hydatform mole: hyperplasia of tophoblastic cells, hydropic swelling of all villi, vessels are usually absent. بالtransvaginal ultrasound هنا راح نشوف snowstorm appearance. هذه البارشال مول راح تشوفون اكو بيبي موجود ويا البلاسنتا. هذه large picture show large bilateral fecal uterine cyst resembling ovarian germ cell tumors with resolution of the human chorionic gonadotropin stimulation, they return to normal appearing ovaries. The differential diagnosis: abortion, multiple pregnancy and polyhydramnion. Treatment aim: elimination of all trophoblastic tissue from maternal systems without undue delay. In preparations: compatible blood should be prepared because of the risk of hemorrhage, blood count, coagulation screen and electrolyte check, correct anemia. Correct anemia. Also DIC and electrolyte imbalance. Chest X-ray should be done to exclude lung metastases which appear in one of the following forms: cannonball, snowstorm, solitary lesions or pulmonary hyperplasia. The treatment: immediate phase evacuation of the mole. The follow-up phase: detections of malignant changes. طبعا التريتمنت اللي بالإميديت فيز أهم شيء ما نسوي DRC جدا خطأ، لازم تكونون suction, dilatation and curettage. لازم نسوي suction لأنه risk of perforation إذا واحد يسوي DRC يعني dilatation and curettage، فاسمه هنا suction, dilatation and curettage. وورا نسوي الفولو اب فيز حتى نتابع إنه أخاف أكو risk of malignancy or not. The suction, dilatation and curettage to remove benign hydatform moles because of the uterus is very fragile to avoid perforation. When the diagnosis of hydatform mole is established, the molar pregnancy should be evacuated. An oxytocic agent should be infused intravenously after the start of evacuation and continued for several hours to enhance uterine contractility. Removal of the uterus, hysterectomy, used rarely to treat hydatform moles if future pregnancy is no longer desired or for controlling of massive life-threatening hemorrhage. Must give NTD in Rh-negative patient. Chemotherapy with a single-agent drug, prophylactic for prevention of chemotherapy at the time of or immediately following molar evacuation may be considered for the high-risk patients to prevent spread of the disease. A high-risk post-molar tophoblastic tumor, a pre-evacuation uterine size larger than expected for gestational duration. Bilateral ovarian enlargement more than 9 cm, fecal uterine cyst. Age greater than 40 years. دول كلهم نعتبرهم high risk. Very high HCG levels more than 100,000 milli international unit per ml. عندها medical complications of molar pregnancy such as toxemia, hyperthyroidism and trophoblastic embolization, villi come out of placenta, or repeated hydatform mole. Follow-up: patients with hydatform mole are curative over 80% by treatment of evacuation. The follow-up after evacuation is a key necessary: uterine involution, ovarian cyst regression, and cessation of bleeding. Follow-up of H mole is indicated for 2 years after evacuation. نبقى نتابع المريضة خلال 2 سنين بعد evacuation. Quantitative serum HCG levels should be obtained within 48 hours. لازم خلال الإيفاكيويشن بعد 48 ساعة نسوي لها بيتا SCG. And then after every 1 to 2 weeks until negative 3 consecutive determinations are obtained. وبعدين نبقى نسوي لها كل أسبوع إلى أسبوعين لحد ما نشوف 3 negative tests. يلا بعدين نحول الفولو اب every month for 6 months. بعدين followed by every 2 to 3 months for 6 months. whatever the method. أول شيء هسه قلنا خلال 48 ساعة after evacuation. بعدين every 1 to 2 weeks. بعدين لحد ما نشوف 3 result negative نحول switch to every month for 6 months. كل شهر لحد 6 أشهر. بعدين كل 2 إلى 3 شهر لحد 6 أشهر الثانية. هذا مهم جدا. Contraception should be practiced. Must not become pregnant at least 1 year, so use oral contraceptive pills in order to follow up the patient without a pregnancy. With other methods of contraception, for example condoms, not use IUCD may cause because of risk of perforation. So the best method is a barrier method and low estrogen pulse. If beta SCG rising or constant يعني احنا من نتابع المريضة شفنا البيتا SCG يا اما صعد يا اما بقى ثابت or plateau or even decreasing نزل بس بقى موجود but still present after 6 months, so there is something wrong. Either new pregnancy اما البيشنت ما ماخذ احتياطاتها وصار new pregnancy or invasive mole بدأت تصير عندها complication or persistent gestational trophoblastic disease. 15 to 20% in complete mole and 5% in partial mole. Expected time for beta SCG to normalize is 14 weeks in complete mole, while in partial mole it is 8 weeks. Counseling. Psychological support. Explain that it is not a malignant disease, but it can lead to malignancy. Counseling regarding complications of evacuation, bleeding, blood transfusion, perforation, emergency hysterectomy. Importance of follow-up with beta SCG titer to discover persistent disease. Use of contraception for 12 months after evacuation. Why? To prevent a new pregnancy. Counseling regarding what to do in the next pregnancy. هسه نجي على complications of HMOL. Immediate عندنا remote complication. Immediate complication اللي هي massive hemorrhage which is not uncommon, so transfusions facilities should be available. Sepsis, antibiotics نستعملها. Preeclampsia may be severe to develop fit. Remote complication اللي هي metastasis and malignant changes. 80% of HMOL undergo spontaneous seduction after curettage. 15% develop local invasive mole, while 5% develop metastatic cordial carcinoma. The identification of malignant changes. Histopathology, no benefit. Serial quantitative HCG, good benefit لأن هو عندنا التيومر ماركر هو التيومر ماركر اللي احنا نسوي بيه follow up. HCG considered as a tumor marker and is accurate indicator whether the disease is progressive or regressive. A progressive disease even after evacuation of the uterus indicate metastasis or malignant changes. The second curettage may be needed. طبعا احنا من البداية لازم نقولها للمريضة نقولها ترى انت احتمال تحتاجين 2 curettage حتى ما تقول بعدين انتوا لا ما نظفتوني زين وتصير مشكلة ورجعتوا عدتوا لي الكيوريتاج. لازم من البداية احنا نفهم المريضة انه انت تحتاجين فولو اب، انه انت عندك ريسك مع المالجنسي، انه انت تحتاجين second curettage. May be needed if bleeding persists for 14 days following the first evacuation because of incomplete uterine emptying. Indications of chemotherapy in HMOL. شو وقت نستعمل الكيموثيرابي بالهيدات فورمول اللي هو قلنا أصلا هو benign disease. First post evacuation HCG level more than 2000 unit per liter. شفنا البيتا HCG تايتر قبل لا نسوي تريتمنت، قبل لا نسوي evacuation، العفو بعد الايفاكيويشن اللي هي خلال 48 ساعة شفناه 200,000. هذا رأسا سويش تو كيموثيرابي. abnormal HCG curve شفناه أول شي نزل بعدين رجع صعد أو مشى بلاتو أو failure to normalize in 6 to 8 weeks after evacuation. Plateau of HCG for 3 weeks. هذول نعطيهم chemotherapy. Evidence of GIT, hepatic or intracranial metastasis, pulmonary metastasis with an increased HCG. هسه نيجي على malignant gestational trophoblastic disease اللي هي gestational trophoblastic disease include a spectrum of interrelated tumors including complete and partial mole, placental site tumor, rare and cordial carcinoma. Gestational trophoblastic disease is among the rare human tumors that can be cured even if the presence of widespread dissemination. Malignant gestational trophoblastic disease, about 20% of gestational trophoblastic disease. احنا قلنا 80% البناين، 20% المالجنت، 50% after H mole month to years تحتاج حتى يصير development، 25% after normal pregnancy and 25% after ectopic and abortion. Classification احنا قلنا ميدز و non meds، يعني non metastatic disease low risk عفوا و metastatic disease high risk. Any disease outside the uterus والميد non metastatic اللي هي local invasive gestational trophoblastic disease placental site trophoblastic tumors. عندنا good prognosis وعندنا poor prognosis. الجود prognosis metastasis short duration last pregnancy less than 4 months. low pre-treatment HCG titer أقل من 100,000 per 24 hour or 40,000. no metastasis to brain and liver. no metastasis prior to chemotherapy. pregnancy event not term pregnancy. poor metastasis poor prognosis meds. long duration last pregnancy more than 4 months. high pre-treatment HCG titer more than 100,000 per 24 hour. metastasis to the brain and liver. significant prior chemotherapy and term pregnancy. التايبس مثل ما قلنا invasive أو cordial carcinoma, invasive mole أو persistent gestational trophoblastic disease هي 75%. الكوريال كارسينوما 25%. placental site of a tumor rare. Invasive mole. This is a common manifestation of gestational trophoblastic neoplasia characterized by the presence of whole chorionic villi that accompany excessive trophoblastic overgrowth and invasion which penetrate deep into the myometrium, sometimes involving the peritoneum, adjacent parametrium, or vaginal vault. Such moles are locally invasive, but it lacks the tendency to develop widespread metastasis typical of choriocarcinoma. Invasive moles originate almost from complete or partial molar gestations. Non-metastatic disease اللي هي locally invasive gestational trophoblastic tumor develops in about 50% of patients after molar evacuation and infrequently after adult gestation. The trophoblastic tumor may perforate through the myometrium, intraperitoneal bleeding, or erode into the uterine vessels, causing vaginal hemorrhage. Bulky necrotic tumor may involve the uterine wall and serve as nidus for infection. بعد عندنا منو placental site trophoblastic tumor is uncommon variant of choriocarcinoma that consists of intermediate trophoblast. low beta HCG راح نشوف عندهم لكن عندهم high human placental lactogen. Metastatic disease اللي هي الكوريوكارسينوما. It is a highly malignant tumor arising from fetal chorion. It is therefore preceded by pregnancy except when arise in teratoma. 50% follow a death-form mole and 25% follow abortion. 20% follow full-term pregnancy while 5% follow ectopic pregnancy. The choriocarcinoma is a malignant neoplasm composed entirely of active chorionic epithelium, which is avillous, necrotic, and hemorrhagic. The tumor invades into the myometrium and metastasizes readily to lung, brain, liver, and other organs. Occur in 4% of patients after molar evacuation, but seen more commonly after other pregnancies, abortion, or term pregnancy. The incidence 1 to 10,000 عفوا إلى 1 in 70,000 pregnancies in the West, 10 times commoner in Southeast Asia. Pathology عندنا microscopic appearance. The tumor appears fleshy in character, is often dark red in color due to hemorrhage, and variable in consistency. It may be single or multiple, invade the myometrium. Primary growth in the uterine wall, but it may be in the cervix or vagina. Mass project into uterine cavity, ulcerate, bleeding, or blood-stained discharge, and if the growth is infected and necrotic, offensive discharge will happen. In advanced cases, it presents as uterine mass with the growth projecting on peritoneal surface. The ovaries are enlarged and show multiple yellowish thin-walled lutein cysts in 10%. هسه نجي الميكروسكوبيك. Complete absence of villi. Most important. هاي جدا مهمة. إنه تماما ماكو عندهم villi. Cellular malignancy in individual cells. Invasion of maternal tissue and blood vessels resulting in characteristic hemorrhage. Hemorrhage with necrosis with inflammatory reaction associated with malignant trophoblast tumor called stomas triad. Okay? اللي هي الهemorrhage, necrosis and inflammatory reaction associated with malignant trophoblastic tumor. Stomas triad. Methods of spread يا أما عندنا direct اللي هي local, it invades the myometrium, broad ligament, tubes and ovaries. The bloodstream metastasis occur rapidly due to eroding power of the tumor, leading to distant metastasis, lungs 50 to 80%, the brain 10%, the bone 20%, the liver 10%. Retrograde vascular spread may give rise to secondaries in the vulva and vagina, 50% formation of secondary deposits in lower part of vagina, vulva. In rare cases, secondaries may disappear after removal of the primary tumor. يعني إذا راح البرايمري tumor, السكندريز هتختفي. The clinical features, symptoms in intermittent or persistent uterine bleeding usually follows molar pregnancy, vaginal discharge, loss of weight and pyrexia, pain due to uterine distension or perforation, symptoms due to secondaries, dyspnea, hemoptysis, cough, neurological, headache and eye troubles. معناها عندنا brain metastasis, hemorrhagic purplish mass at genital tract, تسوي لنا dyspareunia and postcoital spotting or bleeding, and amenorrhea due to increased HCG. الساينز عندنا general اللي هي anemia, cachexia, fever, lung metastasis with pleural effusion, abdominal, enlarged knobby, liver, hepatic lesion. Local عندنا offensive discharge and altered vaginal bleeding, shreds of necrotic materials in vagina, enlarged uterus, symmetrical, firm, irregular consistency and sometimes soft, later becomes knobby and fixed in late cases. Ovaries cystic and enlarged, persistent fecal lutein cyst. The diagnosis of cordial carcinoma. From signs and symptoms, history of labor, abortion or vesicular mole, followed by prolonged bleeding or irregular spotting. Diagnostic curettage of the uterus, endometrial biopsy may give negative result. Biopsy from nodules in vagina and vulva, HCG estimation, high beta-HCG level, positive pregnancy test in high dilution 1 to 500. Serum level of beta-HCG, urea or by ELISA, is more valuable and important in follow-up. X-ray of the chest show cannonball or snowstorm appearance, indicate pulmonary secondaries. Ultrasonography, computerized axial tomography, CAT scan and MRI are very valuable tools for detecting myometrial invasion, pelvic extension and metastasis. The staging of the disease and anatomic staging is adopted by FIGO, but because of insufficient discrimination between low and high risk patients, FIGO added risk factors as substage to each stage. Substage A if no risk factor, substage B if no risk factor, and substage C if 2 risk factors. The stage 1 disease confined to the uterus, stage 2 Gestational Trophoblastic disease extends outside the uterus but is limited to the genital structures, adnexia, vagina, broad ligament. هنا stage 3 extends to the lungs with or without non-genital tract involvement. With stage 4 all other metastatic sites. Note: patients with stage 1 disease usually have low risk score. Patients with stage 4 disease have high risk score because they are most likely to be resistant to chemotherapy. The histologic pattern of cordial carcinoma is usually present, and the disease commonly follows a non-molar pregnancy. The distinction between low and high risk applies mainly to patients with stage 2 and 3. Treatment of cordial carcinoma: the main line of treatment is chemotherapy, as the tumor is chemosensitive. The primary agent of choice is methotrexate. Chemotherapy is the main line of treatment and is effective in all cases, either metastatic or non-metastatic, and in low risk or high risk group. يا أما نستعمل single agent chemotherapy using either methotrexate or actinomycin D is indicated in non-metastatic disease or metastatic low-risk cases. Methotrexate can be given with a folinic acid regime. These regimes are given as repetitive 5-day courses separated by 1-week intervals. Courses are to be continued until remission occurs or toxicity develops. Advantage of this regime: methotrexate is relatively non-toxic and associated with minimal alopecia. Folic acid reduces stomatitis and good results in low risk category. Side effects of methotrexate: bone marrow depression, leukopenia, anemia, thrombocytopenia, alopecia rare, GIT, hepatic toxicity, increased SGOT, LGBT, stomatitis, gastritis, and vomiting, renal toxicity, and photosensitivity. Antidote: folinic acid, leucovorin by IM or folic acid. Actinomycin D, it is antibiotic which binds to DNA, inhibits the development to RNA. Used in resistant cases to the methotrexate, dose IV daily dose of 10 to 12 units per kg, maximum dose 0.5 mg per day. Toxicity: bone marrow depression and skin rash. without a single agent. الcombination therapy نستعمل using aggressive multi-agent chemotherapy and is indicated in metastatic high-risk cases, metastatic low-risk cases with poor response to single-agent therapy. يا أما metastasis وعندها high risk يا أما metastasis with low risk لكن شنو ما عندها response to single agent. The rationale is to use a drug combination with different modes of action without drug-to-drug interaction or dissimilar toxicities. One of the best combinations include etoposide, methotrexate, actinomycin D, cytoxan, and oncovine. The treatment follow-up: during treatment courses, daily blood counts and blood chemistry are determined. The treatment is suspended if toxicity develops or if white BC drop to less than 3,000 per month, platelet drop to less than 50,000 or significant changes occur in liver or kidney function. هسه عندنا احنا كان ذاك medical chemotherapy وهذا هسه surgical treatment of cordial carcinoma, hysterectomy in elderly patients and with complications as severe bleeding, infection, perforation associated uterine or ovarian tumors. فرحتوا هنا كل ساعة تخلص المحاضرة. Hysterectomy in chemo-resistant cases to decrease the tumor tissue and improve response to chemotherapy in high-risk metastatic disease cases. A thoracotomy or craniotomy to remove well-localized resistant focus. However, radiotherapy is now used in such cases with good results. Complete remission is defined as HCG titer that remains negative for 3 consecutive weeks, and the cure is considered if the patient is free from disease for 5 years. Complications: spread, hemorrhage, infection, cachexia, thrombosis, and embolism. The cause of death due to hemorrhage, metastasis, perforation, sepsis, hemoptysis, and toxic effects of the drugs. And thank you very much.